In the fall of 2000, I was diagnosed with breast cancer. I was assured that this diagnosis was just a little bump in the road of life. But this diagnosis changed my life in a profound and permanent way, in a way that I never could have foreseen. I was shocked when test results came back positive for hepatitis C. I had no risk factors, no explanation of how I had contracted this mysterious disease. As the doctor questioned me about sexual practices and substance abuse, anxiety welled up within me. The questions embarrassed me so much that I could not meet the eyes of the healthcare providers as I quickly exited the building. I walked the labyrinth of hallways with anxiety and confusion increasing with every step. I did not know how I would pull forward the courage to go forward in a life with hepatitis C, if I should be able to survive the breast cancer. I did not know how I would go forward as a wife, mother, and healthcare provider. I was so stigmatized by the diagnosis that I told no one about it. I walked this lonely road of worry all by myself. I did not want anyone to know that I had a disease associated with risky behavior. I was afraid that I would be judged a sinner. Public health authorities investigated and found that 99 of my fellow cancer patients had contracted hepatitis C through unsafe injections. Hepatitis C had huge repercussions for patients, their families, the medical community, and the community at large. People suffered emotionally, physically, socially, and financially. At least 6 people died, not from the cancer, but from hepatitis C. The resulting 89 lawsuits divided the community between supporters of the medical system and supporters of the victims. I would venture to say that many in the community are still struggling to overcome the effects of the disaster, now 15 years later. I know that I am. I grieve for the families who have lost loved ones to the disease. I feel betrayed by a healthcare system that transmitted a life-threatening disease to innocent victims. In their honor, I am working to prevent what happened to us from happening to anyone else. We used my malpractice award settlement to provide the seed money for Hepatitis Outbreaks National Organization for Reform, or Honor Reform. Honor Reform is dedicated to prevention of viral hepatitis through injection safety. I vow to never again allow stigma to be part of my life, and I speak out against it with every opportunity. It is rewarding to share my experience with others and to share my hope about life with hepatitis C.
Hello, good morning, and welcome to this session on access to medicines. Before we begin, I just have a request from the organizers with a housekeeping announcement that over lunch there are going to be oral presentations in a side event at the Chagall room. On level M, there'll be boxed lunches, at least that's what they promised, and everyone is invited. My name is Ricardo Leite. I'm a member of the Portuguese National Parliament and the head of public health at the Católica University in Lisbon. And I thank the organizers for the kind invitation to be here and to co-chair this session with my dear friend from Uganda, Dr. Jackson Amon from the Ministry of Health of Uganda. And we are truly honored to be able to co-chair this session today on access to medicines, a very important topic that will certainly help us move on throughout the summit. To try to help set the scene, just to say that we need to ask very honest questions and have a very honest conversation about this and other correlated issues. Why is access to medicines important? Well, we now have the technology to cure hepatitis C, we know that. We have all the scientific evidence we need to eliminate hepatitis C. We know what we need to do from prevention and awareness all the way up to cure and follow-up. And as we've seen throughout the summit, the costs are going substantially down, especially through competition and also through patent challenges, especially in middle and low-income countries. Therefore, ensuring access to medicines is, at the end of the day, a political option. Governments that ensure universal access care are stating that elimination for them is a priority. Those that don't ensure access are saying the opposite, leaving people that live with hepatitis C behind. Let's be clear. Without access, elimination is impossible. But also, with access alone, elimination will also not be achieved. We need to do more. Elimination is only possible through a holistic political strategy that closes the tap to new infections. Doing so through prevention, awareness, and even treatment, working directly with civil society movements and patients, a strategy that diagnoses all the people that are unaware of their status, ensuring that they are properly linked to care, that they are cured, and that we have adequate follow-up. At the end of the day, governments have to take one of two possible paths. Either they implement the policies needed towards elimination of hepatitis C until 2030, or they simply give up and keep the virus within the communities, infecting more people, promoting advanced liver disease and deaths. And doing so, they will be generating a lucrative rent for the pharma industry for decades to come. It is therefore clear that access to medicine is important, but it is only one part of the full needed solution. We need full-stream commitment and leadership from governments around the world to implement the policies that will drive us towards the elimination of hepatitis C. I would say that it is our moral and ethical obligation towards all of those living with hepatitis C, with this deadly disease, to eliminate it within our generation. It's time to end Hep C because it's right and because we can. Thank you.
With that, I want to invite our colleague, Mr. Giten Wairapam from Bangkok, Thailand, to come and give us a presentation on the generic DAA, where they are and for how much. Giten is a community and policy project manager from Bangkok, Thailand. He has been working on the improvement of hepatitis C treatment access and advocating for price reduction in South and Southeast Asia. He has also worked with the National People Living with HIV/AIDS and People Who Inject Drugs Network for hepatitis C. And he got himself involved with a lot of other pharmaceutical companies to address the issue of price and non-price barriers. Because of that, he was profiled as a change maker for hepatitis C by the Economist Intelligence Unit in 2016. I want to invite him to give us his presentation. Mr. Giten.
Thank you so much, Dr. Jackson, and thank you, Dr. Ricardo, for the introduction. Good morning, ladies and gentlemen, and it's really a pleasure. This is my second session in the summit. I spoke once in the pre-summit, and this is such a good opportunity to be speaking to you all as different stakeholders, people who are making decisions, as policymakers in your countries, as physicians who are treating patients, as advocates who are striving and who are asking for access to medicines, affordable quality medicines, as patients asking for your rights, and as researchers trying to bring in the whole set of data to support the movement that we're building on. And welcome once again, and it's really a pleasure to be talking to you. I'm going to talk to you about the generic direct-acting antivirals, specifically for hepatitis C in this session. And I will give you an overview, and a lot of my information is going to be based on the Asia Pacific. That's where we work, and also a lot on the Indian generics, because that happened to be the group of industry segment where we had a larger set of interaction. But hopefully, out of the trust and interactions that we build in this summit, we'll be able to expand this to other industry colleagues, which are not only from India, but also from Egypt, Algeria, and other countries that are in this summit. To provide you an outline as to what I am going to speak on, as I said, I'll be speaking on the direct-acting antivirals for hepatitis C in the Western Pacific and the Southeast Asia Regional Office. Where are these medications? So some of you are not from those, and most of you are not from those regions. So where are these medications in terms of regulatory status? What is it that is available in your countries? What's the pricing? What should you be looking at when you're looking at for your national programs, or for your own individual procurement, or for other matters where you would be getting access to these medicines? I would like to also highlight a bit on what needs to happen to improve access beyond pricing or availability of the medications. So DAAs, we have heard all about this. We heard about Sovaldi, we've heard about Harvoni, we've heard about Daglinza. Those are most commonly used medications, and there are other medications, of course. These are the preferred first-line regimen that has been, preferred regimen, not first-line, but preferred regimen that has been recommended by the World Health Organization. We also have seen generic formulations of these medications, of sofosbuvir, ledipasvir, and sofosbuvir co-formulation, daclatasvir, and I'm just highlighting some of the Indian products which I can access to, and I would like to note that there are similar formulations that have come out from Egypt, that have come out from Algeria, and I would like to take those into consideration, and also other countries that I may not have cited. In WIPRO, this is the Western Pacific, we have a large number of countries, but the availability of these medications are slowly growing. It's not to the extent that we would want, but availability of DAC or soft lead, it's growing. You would note that velpatasvir outside of India, in the Western Pacific region, has already been approved in Cambodia. You would also note that Vietnam allows a system of procurement prior to formal registration of a drug. You should explore such, as clinicians, as policymakers, or as researchers, you can also explore in your country if this kind, it's called as different terminologies or different nomenclatures, but in Vietnam that's called as a special import license. Import of drugs, import of medications prior to a formal registration of a medication. So that's something which is allowed. In the Sero region, we have heard about, the Bangladesh. They are an LDC, so they don't have to provide patent on the medication, so they have a large production of the generic DAAs, including soft and velpatasvir co-formulation. India, as we know, has the largest licensees of the originators, and also please note, there are other suppliers or manufacturers who are outside of the license and have produced and not yet marketed, but the products are in there. So it's not just the licensees of the originators, but also other products that are from other companies. Again, Indonesia allows similar thing. They call it as a special assistance scheme. Indonesia allows similar prior to formal registration of medication, and this has been used quite to an extent by big referral hospitals in these two countries. There are other countries. Yesterday, Zimbabwe also cited an example of special imports. So maybe these are avenues which you can access if you do not have formal registration. Please explore that. Now, I want to show you. So we've heard about this, the voluntary license, and how many countries are actually been provided license with or in the licensed territory. Sovaldi, as we know, 2013 December was approved by the FDA. Generic licenses, September 2014, first licenses to Indian generic companies, later expanded sometime in beginning of 2015. Harvoni approved 2014, October, and then Daglinza, July 2015, and MPP got a license for daclatasvir in November of 2014. If you look at the real number of registration, now Gilead it's so hard to see from here. It's 105 now with 2 Eastern European countries and 2 including Thailand and Malaysia. It's 105 countries. But if you look at the real number of countries where it has been approved, it's fairly lesser in developing countries. You can see the number of countries. Daclofenacin is only in 10 countries, and sofosbuvir is only in 3 countries. Let me break this down. The point is, the licensed territories are a lot, but we are having a serious regulatory lag. If there are people from the FDAs here, or Ministry of Health, I know some of you are here from the Ministry of Health, we need to work on fast-tracking this medication to ensure that our patients and our physicians and our public health programs get access to these medications as quickly as possible. So outside of the territory, your countries might be here. It might not be updated there might be a little bit up and down to this, so if there's a feedback, I would happily appreciate getting that onto some of the countries that have been approved or not approved. So in the case of sofosbuvir from the Indian licensees, there are 23 countries where Indian licensed manufacturers have been able to register their products. 31 are still pending, and some of these 31 are more than 2 years. That's too long a national regulatory lag. You look at ledipasvir and sofosbuvir co-formulation, the number decreases, whereas countries where genotype 1 and 6 predominantly exist or could have been taken care very well still have pending registration for large number of years. So we have 10 countries at the moment where sofosbuvir has been approved, and 16 countries pending. You can check from the list where these are approved or pending. We also, if you go to daclofenacin, we have 10 countries and 20 pending. Now, 23 approved for sofosbuvir and 10 only for daclofenacin. And knowing that we need this combination, and some of the professional societies have already approved sof and dac as a pan-genotypic regimen, and some of the companies already have sof and dac co-formulated tablets. We need sofosbuvir and daclofenacin to be together. You cannot, and we cannot afford to put people in this era of DAAs on sofosbuvir and ribavirin 24 weeks therapy. That's a suboptimal therapy. It's not ethical, and it's not clinically sound. Velpatasvir, again, it's approved, as I say, in 3 countries, and 1 it's ongoing right now. People who were in the pre-summit would have seen this slide, and we can get in India. This is individual purchase. So if you want to purchase in India, any bottle of sofosbuvir, you would get it as low as $55. Daclofenacin, $23, and $93 for a bottle of soft lead. This is individual purchase. So if you go to India, if any one of you or your patient, anyone is going, please keep this in mind, that this is a reference price that you have if you're buying as an individual. Sovled launched velpatasvir and sofosbuvir launched in May, has got a considerable drop in terms of pricing. We can get it as individual purchase approximately at around 10,000 rupees, which is around $162 US. You look at the price in the government procurement. Think if you can get this as a part of your government program, and why not? If the Indians are getting it, why not? Why not your own governments? Why can't we do that? Sofosbuvir, $14 and $12 for a bottle of DAC. Sofosbuvir at $14. So yesterday we have heard from our Farco colleagues saying that we're giving it at $84. We see the MSF announcement at $120. You look at the Indian pricing, it's around $78 for a soft with non-cirrhotic patient for 12 weeks. Even if cirrhotic patients are there, you're going to double it up probably, or use of velpatasvir as an option. So this gives, if you have that pricing point where governments and public health programs and international funding agencies are willing to listen, then this perhaps is one way of looking at it. Generics doesn't mean necessarily you will get an affordable price. So I'm just showing you, and this is to my industry colleagues in this room, I understand the articulation to say that we don't have a control on the price, but it's the distributor in those countries who fixes this price. But then you have a responsibility to tell the people that you cannot sell it at that price. If the same drug that you're selling at $55 or at $15 to the government in India is being sold in Vietnam at $570, that's not a sound practice. Please see how you can talk to the people, talk to the government, talk to your local distributors to see how you can make this price better. What needs to happen? We have to find the patients We have to find the patients. We heard 25% only have been diagnosed out of that 71, out of the 71 million. We have to find those patients. We have to register. As I said, the graph shows that we have to fast-track this medication. It is there. It's there as listed as 101 or 112 countries, but it doesn't make sense so long as our patients and physicians and our public health programs do not get access to that. We have to make it more affordable. Vietnam, Cambodia, in my region I'm just talking about, it's the same probably in Africa. It's the same somewhere in Latin America. Those are not affordable pricing, either for the government or for patients. But please see how you can. Mongolia is a good example. India, Egypt, these are good examples. Mongolia did. I'm sure there are colleagues from Mongolia. Please catch them and talk to them how they did it. They got 4 or 5 companies, both generic and originator, and really gave good fast-track registration. So how we can replicate similar kind of things and making sure that patients are getting at $50, $60 a bottle. We have to expand treating pool of physicians. And task sharing, I wouldn't say the word task shifting as such, but task sharing. There are a lot of patients, I don't want to name the countries, but if we are restricting only to gastro doctors, and we are considering only, to most of the cases, only hepatitis C patients, we don't take into consideration millions of hepatitis B patients that are not being addressed too. So if you put those pooled together, with due respect to, again, A, B, A, D, and E, if we pull those, it's impossible for the Hepatology and the Gastro Society to be treating all these patients. If we are to eliminate, if we are to proceed, then we have to agree on task sharing and build the skills of non-specialists and GPs, as like what Australia have cited in earlier session. We need to do that. We have to help one another to ensure that we are having a larger coverage. And last but not the least, political will. And this is what we are talking about, and that's why in the earlier session we have all the ministers coming in here together to say how we are doing and how we can share our experiences and skills to be moving ahead together and ensure that we get a 2030 elimination target together. Thank you very much, and I'll be happy to take questions at Q&A or later.
Thank you, Gitten. And we're now moving quickly on, after this inspirational presentation, to Andrew Hill, who is a Senior Visiting Research Fellow at Liverpool University in the UK, specializing in treatment access issues. And Andrew has worked as an advisor to WHO, works as an advisor at WHO, UNITAID, and at the Clinton Foundation. And he's going to talk to us about what price for what drug. Is there a science to it? Floor is yours, Andrew. Thank you.
Thank you very much. I'm going to start off this morning by looking at where we've got to in 2016. So 2016 was a year where there was a good pool of diagnosed patients who were linked to care, well insured. It should have been a year where we treated a lot of people. 1.5 million people cured last year. At the same time, 350,000 people died from Hep C, and just over 1 million people died from non-Hep C related causes. So the 70 million has come down. However, in the same year, we have 1.6 million new HIV infections. So the epidemic only went down by 1.8%. If we carry on treating at the rate we were treating in 2016, we are not on the road to elimination of hepatitis C. It's not enough. If you look worldwide at the change in the epidemic year on year, you can look at countries like Russia, where last year the epidemic actually got worse by 4%. India, where it went up by 1%. The countries in green, a few countries are leading the way. They're showing the kind of treatment rates that you would need to get elimination of Hep C by 2030 if they carried on at this rate. So Australia, Egypt, Spain, Japan, USA. But there's a big if there. The easy patients have been treated. Now we need to look at the patients who are not diagnosed, not linked to care, don't have health insurance. It could be a lot more difficult in the future. If you look at diagnosis rates worldwide, the countries in green have very high diagnosis rates. You look at Australia, Canada, Scandinavia. However, there are a lot of other countries with very low rates of diagnosis, including most of South America. And even if you look at new diagnoses, so this is total diagnoses, new diagnoses, again, very, very low rates of new diagnoses. And it could reach a situation where we get diagnostic burnout and countries simply run out of patients to treat. Most of South America is in that situation. So we need to diagnose and treat not 1.5 million people a year, but 5 million people a year in order to get to these WHO targets by 2030. Now, can we afford this? And what's the real cost to cure hepatitis C? My research group look at databases of drugs being manufactured in China and India, and we calculate across a range of diseases what treatments should cost. So we have this database of India Infodrive, which shows drugs being exported as raw materials from India to other countries. And if you look on that database and you look at hepatitis C drugs, you could go to India tomorrow and you could buy a kilogram of sofosbuvir for around $1,000. Now that's enough to treat 30 patients for 12 weeks. You could go to India, you could buy a kilo of declatosphere for about $1,000. That's enough to treat 190 people. You then have to include other costs. You've got to package the drug, you've got to make it into tablets, you've got to have a profit margin for the generic supplier. But they're quite trivial costs. And the actual cost of making a 12-week course of sofosbuvir declatosphere is $47 US. Now, every time I present this, I've been presenting this information for the last 4 years, it keeps going down. I was talking to a professor of chemistry in Washington last week, and he says this is too high. He says by the end of this year, it's going to be about $40 US for a 12-week course of sofosbuvir declatosphere. If you then contrast those costs with the prices of the drugs, you can see that these same drugs are being sold in the United States for incredible prices, just massively high prices. But you can also see that across HIV, hepatitis B, and tuberculosis, it is possible to buy drugs for a range of diseases at close to the cost price. So you can buy a course of treatment for a year for HIV for just over $100 when it costs $82 to make. You can buy a 12-week course of treatment for hepatitis C for $78 when it costs $47 to make. So this isn't just theory, this is actually happening. And as time goes on, we should be approaching this $50 unit price for hepatitis C. And just as the mechanisms to allow access to HIV treatment in many different countries all over the world have come into place, it should be possible to provide these treatments at this cost for hepatitis C as well. Now, if you then look at the range of prices across countries, it's just amazing. So you have a drug that costs $47 US to make, being sold in the United States for $140,000. It's just mad prices. If you look at the sales of all hepatitis C drugs since their launch in 2014, the total amount is $66 billion US, and every month it goes up by another $1 billion. The profits from Gilead in 1 year alone were $18 billion. And it makes you think, what is the amount? How high does this have to go before the prices start to come down? This has easily paid off all the costs of research and development. Anybody who says, well, we need to continue research, it's just ridiculous. We have paid for that research many times over. And even at this point, with all that money that we've spent, we're still not on the road to eliminating hepatitis C because we're not treating enough people. So the real cost of hep C elimination, if you imagine you've got 70 million people and you're treating, for a course of treatment is $50 US, you could treat all 70 million people for $3.5 billion US. That's equivalent to 10 weeks of sales of these drugs at the current prices. There is enough money around to eliminate hepatitis C. It's being used wrongly. The drugs are far too expensive, and that's why we're not on the road to elimination of hep C right now. Do we already have good quality generic drugs? Somebody might say, well, it's $47, but is the drug meeting the highest quality standards? How well do these drugs work in clinical practice? So my research team has been looking at the efficacy of these drugs as generics in a whole range of countries. We've looked at bioequivalence. These are all bioequivalence studies from a range of companies showing that if you look at the concentration in the blood of sofosbuvir or declatosphere from a generic, it's exactly the same as the concentration when they take the version from Gilead. The same thing for declatosphere. The concentration when they take the generic is exactly the same as the version from Bristol Myers. And then you could say, well, is sofosbuvir declatosphere the best treatment to take? This is a randomized equivalent study run by AbbVie looking at sofosbuvir declatosvir for 12 weeks versus what a lot of people say is the best treatment around there, the GP from AbbVie. And after 12 weeks of treatment, 97% of people who took Sofdac were cured versus 95% on the AbbVie compound. This is the best treatment we have available, even for this very difficult group of people to treat with genotype 3. And then we look at the cure rates across different studies of these generics when used in buyers clubs. So people have the right to bring these drugs into the United Kingdom, into Australia, into other countries, if they can't access them locally. And we've worked with these buyers clubs as they bring drugs in, and we've done surveys of how many people are cured. And you can see across the range of genotypes, we have very high cure rates using these generic drugs. And if you look, we work with the Russians. The Russians have treated thousands of people importing these drugs as generics with a 98% cure rate. We've worked with the Southeast Asians, 93% cure rate, and across a whole range of countries and a whole range of different genotypes. The Australian Buyers Club, again, thousands of patients, 93% cured. So nobody can say that these generics are poor quality, they don't work. They very clearly work. So we already have high quality bioequivalent generic drugs available which can cure hepatitis C in over 90% of patients. Sofosbuvir declatosvir is equivalent to the best treatments for hepatitis C that are currently available. The minimum prices are already $76 in Egypt, very similar prices in India. We are getting to these low prices, but I think in any country you need to ask yourself, are you able to treat as many people as you like? And the answer is almost always no. And if the reason for that is high price, then you need to talk to the people involved in the access and the pricing systems. And we should be able to get these prices in a whole range of countries, with the generic countries using a similar mechanism to the Global Fund, and in the non-generic countries through a range of negotiations or compulsory licenses if necessary. And some of these drugs are already pre-qualified by the World Health Organization, or they've been approved by the Global Fund. So pharmaceuticals, we've got to be very clear on this. $66 billion, I think that's enough. You might not agree with me, but I think that's a very, very large amount of money. The profits have been made. This is enough. And now it's time to lower the prices. And we should be getting prices for low-income countries in the range of $50 to $150 per cure. For middle-income countries, they deserve to pay a little more, $150 to $500 per cure, and high-income countries, $500 to $3,000 per cure. Companies can still make money by treating large numbers of people at small profit margins. And so we have the equipment, we have the ability to eliminate hepatitis C worldwide, but we've got to start negotiating harder. Thank you very much.
Thank you so much, Andrew, for that presentation. Our next and last presenter for this session is Dr. Ivan Putin, who will discuss with us options for treatment access in countries with and without access to generics and the role of different actors.
Good morning. I will try to speak in 10 minutes to share with you the latest data that we have in terms of treatment coverage, and also to guide you to the 4 breakout sessions that will be available shortly from now. The overview of my talk will be, as I mentioned, to share with you the latest data on access, to discuss the various factors that can influence access, and then to also discuss briefly approaches to procurement of affordable medicines. So first, the current status of access to treatment. On the slide, you can see the latest estimate of the cascade of care for HBV infection in 2016. In the Y vertical axis, you can see the number of infected by WHO regions according to the color code. The second bar is a proportion of those that are diagnosed, with the gray that show the gap. The third bar is the proportion on treatment, and the last bar is the proportion of those treated that are virally suppressed. So you can see that we have an increase in the treatment access for HBV, but that we have a large diagnosis gap that remains. We do not calculate the treatment gap for HBV because right now we lack information on the proportion of those with chronic infection that are actually eligible for HBV treatment. On this slide, you can see with the same reference, the same axis, the cascade of care for HCV infection by region in 2016, with those infected, those that are diagnosed, and those that have started on treatment in 2016. So here we're able to calculate the gap. So as it's been discussed earlier in this meeting, the number of people that started treatment in 2016 has increased from last year, but as also been said before, not enough. Now we'll be discussing the factors that influence access between registration, procurement and supply management, policy and guidance, service delivery, prices, and financing. So as you see, the price of medicine is one aspect, but it's not the only aspect. What you want in your country is a certain amount of policy and guidance. You want to make sure that your treatment guidelines are aligned on the WHO recommendations for clarity. You want to make sure your medicines are included in the essential list, and you want to make sure you also know how many patients you want to treat. You need a service delivery model that is adapted to all the patients that you have with linkage to care and community engagement. You want registration, procurement, and supply management. So it's important, as been mentioned by Gitten, that if you have access to the possibility of buying generics, that you also register these drugs so that they can be procured in your public health system. You need to ensure that the quality standards are met, and the WHO pre-qualification system is one of the key systems that's available to help you finding your way to the quality issues. And then you need to work on price reduction strategy that can work through launching a tender if you have competition between multiple generics to decrease the price, or use pool procurement mechanisms such as the PAHO strategic funds, or if you're dealing with only one manufacturer, you would need to engage in sole source price negotiation. Finally, there's a price, economic, and financing issues. You may want to use economic analysis to reduce, to find out the pricing level at which you will be cost-effective or cost-saving, implement policies to overcome intellectual property barrier, and develop a financing plan. So access, as we've just discussed, if we have this comprehensive approach to access, then access is more than just making medicine available. It's a comprehensive approach that makes sure we have the right product in the right places, at the right time, at the right price for all the people that need it. Now I will go a little more technical and refer to the procurement of affordable medicines. So there's two different situations in terms of access to generic, and here I'm talking about the possibility of the countries to buy generic medicine. So we have countries that cannot access generic medicine. This is because the country might not be on the voluntary licensing list, or there's a patent that has been granted and that is valid. So in that case, you need to procure from the original manufacturer, and there's no competition, and you may have higher prices. And there are another situation with country that can access generic medicine because a patent had not been granted or it's been successfully opposed, because there's been a voluntary licensing agreement, or because there's been compulsory licensing. In that situation, you can buy generic medicine, and hopefully you can open a competition that will lead to price reduction. Now I will discuss how these two scenarios apply to the B and C medicine. In the field of HBV medicine, you need to be aware that most people with HBV infection live in low-income country or middle-income country. All these people live in countries that can procure generic medicines. And the quality generic medicines are available for less than $30 a year in the case of tenofovir. However, very few countries have a public health program. So in the absence of a public health program with the public sector procurement, what happens is the procurement gets fragmented in the public sector, and there's artificial high pricing. So if you live in one of these countries And if you had to start a public health program, you should be able to access tenofovir at less than US dollars 30 per year. Now, the other countries that still have no capacity to buy generics, this will go away in 2018 because the patent for tenofovir will expire. So that applies to most high-income countries, China and Mexico. Now, on this slide, you can see the proportion of patients on HBV treatment among the subset that have been diagnosed. So this is only the 27 million diagnosed. So this is the coverage on treatment for low-income country on the left, lower middle-income country, and then upper middle-income country and high-income country. So you can see that China accounts for most treatment, despite the persistence of a patent, which is going away next year, as we mentioned, and that the treatment coverage is still low in most places, including in places that theoretically could procure it for less than $30 a year. This is the same graph showing the treatment, the new treatment for HCV in 2016 according to the income level. So 62% of those infected with HCV live in countries that could theoretically, that can procure a generic medication, but there's also the obstacle of registration. But the situation remained, the treatment onset remained low in most areas, apart from maybe the low middle-income country where we have the leading role of Egypt and Pakistan with a lot of people being placed on treatment. So in summary, the access to HBV treatment remains low. The access to DA for HCV treatment is heterogeneous across income groups. And procuring generic medicine can increase access and reduce price through competition. Now, what we wanted to mention also as a conclusion is that each country's situation is different, but there are lessons to be learned from each other. So this is why we would like to break you out in 4 different groups for the remainder of the discussion. So if you live in a country that is not in a position to buy generic medicine, you may want to go to the first session where we will be discussing together options to decrease prices through intellectual property issues, patient oppositions, and compulsory licensing. If you are in a country that had the possibility to procure generics, then you want to understand how you can make a better use of these generics through good procurement practices and competition. So that will be discussed in the second breakout session, and you will find out how generic can help, how you can make the best use of voluntary licensing, and how pool procurement can also help you decreasing the prices. Now, irrespective of the access to generic, if you're part of the civil society and you want to find your role in increasing access to treatment in a broader perspective, please join the third session and hear about effective advocacy by the civil society. And finally, if, like me, you're one of the data nerds, or if you're into monitoring and evaluation, join us in the fourth session, where we'll be talking about documenting and reporting access to treatment with the tools to manage patients, such as patient cards that can be aggregated in patient database and then lead to a cascade of care estimations for good monitoring and evaluation practices. So thank you very much for your attention, and we look forward to seeing you in one of the 4 breakout sessions.
Well, thank you to all speakers for complying with time and for such stimulating discussions and presentations that I think will lead to very productive breakout sessions, as we just heard. So we're now opening for no time for Q&A, and so I just got that message. I'd just say, if there's any burning question, just stand up. Okay, we'll take one, and then we'll have to really close the session. Thank you. Please state your name and where you're from, please.
Thanks. Ben Cowie from Melbourne in Australia. It's not a question, but just to highlight that there's another session on as well from the submissions presentations at 12 o'clock in parallel in the Chagall room on level M. on service delivery models for testing and treatment, in addition to the other 4 excellent sessions on offer.
Okay, you used our free publicity. You got it. Okay, well, I really have to end now. On my behalf and on the behalf of my co-chair, we're truly honored to chair this session, and we thank all speakers in this panel, and we wish you productive side sessions and a good lunch. Thank you very much.